Today we'll be asking the question, what do myelofibrosis tests tell your doctor? With Dr. Siri Tantravahi from the University of Utah. Have you ever wondered what those tests that have you ever wondered what the test that your doctor orders for myelofibrosis actually tells them? Today, Dr. Tantravahi, a myeloid proliferative neoplasm expert, will help us learn what, why, and the what, when, and why of testing for myelofibrosis patients. I'm going to introduce Dr. Tantravahi really quick. Dr. Tantravahi is an associate professor specializing in hematology and hematologic malignancies within the Division of Hematology at the Huntsman Cancer Institute at the University of Utah. Board certified in hematology and medical oncology, Dr. Tantravahi is an expert in the management of leukemias, MPNs, and bone marrow failure, as well as genetic predisposition to related conditions. After completing his internal medicine residency and hematology oncology fellowship training at the University of Utah School of Medicine, Dr. Tantravahi joined the University of Utah as faculty in 2015. He actively engages in pioneering clinical trials, investigative innovation, therapeutic strategies for myeloproliferative neoplasms, chronic myeloid leukemia, acute myeloid leukemia, and acute lymphoblastic leukemia. Dr. Tantravahi is a member of the American Society of Hematology, Society of Hematologic Oncology, and American Society of Clinical Oncology. His clinical and research focus extends to the diagnosis and treatment of telomere biology disorders, with a particular emphasis on unraveling the genetic mechanisms underlying these disorders and various germline predispositions to bone marrow failure and leukemias. Thank you for joining us today, Dr. Tantravahi.
Dalton, thank you for the kind introduction. And also thank you, HealthTree, for inviting me to participate in this session. You hear me okay?
Yep, we can hear you.
Perfect. Excellent. All right. So thanks for everyone else for joining. As Dalton said, I'm a hematologist that specialize in treatment of leukemias, particularly myeloproliferative neoplasms. I think I was asked to talk about sort of specific tests that we do in myelofibrosis. So I think what I'll do is I'll give you a quick rundown of how I approach when I see someone with myelofibrosis. What are all the tests that we need to make that diagnosis, and also understand more about the disease in a specific individual, and how do we use all this data that we get from these tests to sort of figure out a specific treatment plan. Does that sound good, Dalton? And then we can take questions after that.
Yeah, that sounds perfect, I think.
Excellent. All right.
Yeah.
So before we go into, sorry, my office is a little bit of a mess in the background. Ignore that. Before you go into the specific tests about what tests that are important and how to interpret these, it is also important to kind of understand how these patients actually present themselves to either primary care doctor or hematology clinics, and what makes us suspect about this particular condition. To give you a little bit of a background, myelofibrosis is considered a blood cancer, and it is considered to be a chronic leukemia. In the old days, we call these as myeloproliferative diseases, but after we recognized that these are actually sort of chronic, slowly developing blood cancers, they're sort of rephrased as myeloproliferative neoplasms. So neoplasm is basically in anything that's cancerous. And it belongs to this category of diseases called MPNs, and within MPNs, there are three specific classic MPNs that don't have the Philadelphia chromosome, and those are polycythemia vera, essential thrombocythemia, and the third one is myelofibrosis. The reason I'm bringing up the other two classical MPNs is that myelofibrosis can show up as de novo. That means that when patients get presented and get diagnosed, they already have something called primary myelofibrosis. But it can also develop with a pre-existing blood disease, such as PV and essential thrombocytosis. So those sometimes referred to as secondary myelofibrosis. But regardless, it is important to understand that the treatment and prognosis to a large extent is similar. Most of the patients with myelofibrosis, unless they've had pre-existing PV or essential thrombocythemia, often present to the doctors with either a wide range of symptoms. One of the most common symptoms is fatigue. And then there are other symptoms such as bone pain, muscle pains, and night sweats are some of the common ones. And you can imagine that many of these symptoms are non-specific, and an average medical professional who doesn't treat these diseases don't often think about this, when a patient presents with fatigue. So most of the time, these patients have blood tests done, and there are abnormalities on the blood counts. And when I get these referrals with a suspicion of either myelofibrosis or MPN, the first thing that's pertinent to myelofibrosis in particular that we evaluate is, in addition to, first the symptoms that are bothering. And the researchers over the years have come up with specific sort of questionnaires so that we document the most predominant symptoms and the symptom burden in a more formal way. So we have something called myelofibrosis symptom assessment form, and that's been sort of modified. So we use that to determine, how many symptoms they have and also the symptom burden. And then the next thing that I typically evaluate is, in addition to what's bothering the patient, is what their medical background is, what kind of conditions they have, and comorbidities in a way. That do they have high blood pressure, diabetes, cardiac diseases? It's important to document all of that because we need that information sometimes, in order to determine when somebody is eligible for transplant or not. The next thing look for is on physical examination. The most pertinent things to look for is whether an individual with a suspected myelofibrosis have an enlarged spleen or not that we can feel on clinical examination. So it's important to examine for spleen enlargement and also sort of document if it's enlarged, how big it is below the rib cage that we can feel. And then the next step is coming to the main center of our discussion today is sort of what tests that we need to determine the diagnosis. So I'll break it down into, most of the tests that we do are essentially blood tests and a bone marrow biopsy. So in the specific blood tests, what we want to look at is someone's complete blood count, or in some countries it's called as full blood count. So basically it's a complete blood profile where we get different parameters of the blood cells. That includes the total white blood cell count, differential count, which means how many different types of sort of the white blood cells, such as neutrophils, and also the characteristic feature of myelofibrosis is we often see immature white blood cells in the blood. That's part of the diagnosis. So we look for that component of the specific part of the white blood cells and what percent are immature. And then the next thing is to look at the hemoglobin concentration and hematocrit. So some of the patients with myelofibrosis have anemia, which means that they have a low hemoglobin concentration in their blood or low red cell count. And then the platelets. So white cells, hemoglobin, and platelets are the most important part when we look in the blood counts to determine whether someone had anemia or low platelets. And then, the type of abnormalities we see in the blood counts is quite variable. Some patients do present with high white blood cell count, and very rarely some present with low white cell count. And our observation typically is that if they have high white blood cell count, that means they have more proliferative disease and perhaps more symptoms. And then, as I already said, we look whether somebody has anemia or not. If they have anemia, how severe it is. Is it mild? Is it moderate or severe? The severity is based on sort of the concentration of the hemoglobin and how low it is. Typically, when it approaches, when it's below 10 and approaching 7 and 8, that's when people have more symptoms. So we call that as severe. And often those patients require, transfusions to improve their symptoms. So the next, after evaluating the blood tests, obviously blood counts, we'll also check liver function tests and kidney function tests just to make sure that they're all normal in order to determine whether somebody can, if they go on treatment with JAK inhibitors. And then there's one specific blood test that I also do is something called LDH. It is basically a measure of this particular enzyme in the blood called lactate dehydrogenase. The importance of that is that most patients with, almost all patients with myelofibrosis have an increase in LDH concentration. And in fact, it is one of the minor criteria to make a diagnosis of myelofibrosis. So that's why we do that, because if there is somewhat ambiguity, whether they have MF or not, and if someone has a high LDH, then I have an increased level of suspicion. Obviously, the most important test that we need to determine the diagnosis of myelofibrosis is a bone marrow biopsy. And most people who face this diagnosis have already had at least one, if not more than one. And without going into details how the sample is obtained, the key part of myelofibrosis diagnosis is to look at this so-called triphyine core biopsy, where we look for the amount of blood cell production in the bone marrow. And often in myelofibrosis we see much higher number of blood cell progenitors. These are basically before mature blood cells are formed, you have several immature cells in the bone marrow, and those are sometimes called progenitors. And they can be part of the disease as well. And so the first thing is, to look at under the microscope, to look at these, if there are any abnormalities on how these cells look under the microscope. But then the next step is to determine whether someone had fibrosis. So in order to determine the fibrosis, they do specific stains for 3 different components. One of them is called reticulin. Typically, myelofibrosis is diagnosed based on the degree of reticulin fibrosis. And experienced pathologists can grade it from grade 0, where you don't see any fibrosis, to grade 3, where you see extensive fibrosis. And 1 and 2 are mild and moderate. And there are specific scales for the pathologists to come up with, what they see. And in most myelofibrosis patients, we see something, at least grade 2 fibrosis, if not grade 3, and that's for reticulin. And then they also look for another component called collagen, and also something called osteosclerosis. So you need these sort of specific special stains to look for this reticulin, collagen, and the other fibrosis in order to sort of make the diagnosis. The next thing is the most important part once we see fibrosis is to determine as some of who have the disease, is that 90% of myelofibrosis patients have a mutation in one of three genes. And those are JAK2, calreticulin, and MPL in the order of frequency. So we do something called next-gen sequencing for a panel of genes that includes these three as well. These three are considered driver genes because most patients with myelofibrosis, if they have a JAK2 mutation, you would not expect to see calreticulin. So that means they're mutually exclusive. That's why we think that they are driver genes, because if you have one, you don't need a second one in order to, have certain growth advantage. So we look for that. So to characterize what specific mutation somebody has, because that's important to determine not only prognosis, but also to make the diagnosis as well. And then the next-gen sequencing will also include some of the other genes, which can be mutated along with the JAK2, calreticulin, MPL genes. And some of them have sort of relevance in determining how advanced the disease is, and we can actually predict to some extent survival. But at an individual patient level, it's hard to tell. But when we look at a lot of myelofibrosis patients, if they have certain gene mutations, we would consider them as high risk as opposed to if they don't. So getting that information, sometimes when I see community referrals, that's not always available. They weren't already done the testing. So it's important to do that so that we get a sense of how advanced the disease is, whether somebody has high risk mutations or not. So, and then there are certain tests that are also sort of ancillary important is we look at chromosomes. One of the important part of chromosomes is, do we see any alterations in numbers of the chromosomes? Most myelofibrosis patients have normal chromosomes, but there are certain abnormalities that are considered high risk, which are part of some of these prognostic risk stratifications. So that information is sometimes useful, whether to determine whether somebody has a high risk abnormality or not. One of the other important things when we analyze the chromosomes is there's a specific disease called chronic myeloid leukemia, and that's caused by Philadelphia chromosome. And some of the patients with chronic myeloid leukemia, it can look like myelofibrosis. You can't tell the difference based on the blood counts or their symptoms. So it's important to determine, to make sure that they don't have Philadelphia chromosome. So we do that routinely. In addition to looking for the JAK2, calreticulin, and MPL mutations, we also make sure that they don't have Philadelphia chromosome, because once you have Philadelphia chromosome, it is not myelofibrosis. It is considered chronic myeloid leukemia. And then there are, other tests to also look for, sometimes what is the blast percent, because most myelofibrosis patients have so-called chronic phase. That means they don't have high number of blast counts, any higher than 10% in the blood or bone marrow. Almost all MF myelofibrosis patients have a little bit of blasts in the blood, but that doesn't mean that they're transforming to more aggressive leukemia. The percent matters in this situation. If there are more than 10%, and then it is considered accelerated phase. And if it is more than 20%, then it is considered leukemic phase. And the way we determine the blast percent in the blood or bone marrow is sometimes we do this test called flow cytometry. Dalton was mentioning that earlier. So there are different, every test has a specific reason, whether to make the diagnosis or to determine somebody's risk in terms of other mutations, for example, or whether we're ruling out and confirming that this is myelofibrosis. So it can be daunting to look at a bone marrow biopsy results, and it's sometimes important to kind of break it down, whether we have all the information to make the correct diagnosis. And if it's not very clear, it's important to sort of ask questions about it to your doctor. That's kind of, sort of the rundown. I mean, once I have all this information, so typically what I approach is I do these blood tests to look for complete, their blood counts, kidney functions, liver functions, LDH, and what's the percent of blasts in the blood. And then I do a bone marrow biopsy. And then what I do typically is that for me to get all the results that we need takes about 2 weeks. So I always make another appointment in 2 weeks. And then once I have all these results, I will sit with the patient and then go through every single thing individually and kind of explain um, the importance of each result in that. So that's a long, sort of rundown, but that's kind of what it takes to make this diagnosis.
Excellent. Thank you for that, Dr. Tantravahi. I think that was really informative. I know that there's, like you said, it is kind of a long rundown. There's a lot of tests that go into not just diagnosing myelofibrosis, but getting an accurate and clear picture for diagnosis. And I think you did a beautiful job explaining that. So we've now come to the Q&A portion of our presentation. This is your time to ask Dr. Tantravahi any questions that you may have regarding why these tests are done, a little bit more information about these tests, anything along those lines. You can ask those questions via chat, or you can unmute yourself and ask them verbally. If you need to hop off prior to the completion of the Q&A, that's totally fine. We understand. You'll still have access to that post-event survey. And again, we ask that you fill that out before you leave. But yeah, looks like we've got one question in now. Let's see if I can get my Zoom to cooperate. All right. Which test should be repeated after diagnosis and how often?
Excellent question. Once we make the diagnosis, the first thing that needs to be determined is whether somebody needs treatment or not. Not all patients with myelofibrosis require treatment right away, but we think eventually most people require treatment. So regardless, let's say if we're not doing any treatment, then typically I test blood counts, which is CBC, at least every 3 months. And sometimes if I have a little bit of a higher concern, I may want to do blood counts every week. And then not only blood tests, but it's also important to see the patients for follow-up, where I keep an eye on their symptom burden and also the spleen size by kind of clinical palpation. And the other thing is that if let's say if somebody presents with myelofibrosis and they have a big spleen and have several symptoms, the treatment is, as you may know, is so-called JAK inhibitors, and ruxolitinib is the most common drug. When we start treatment with ruxolitinib, I often repeat blood counts almost every week in the first month, because ruxolitinib can sometimes drop the red cell count or hemoglobin or the platelet count. So it's important to keep monitoring for any sort of worsening of blood counts on treatment. And then after that, depending upon what we see, we can kind of space it down. Every month. I often do at least every month. In terms of doing more specialized testing, that is, repeating a bone marrow biopsy, for example, or looking for mutations, whether the mutations are changing, that's often, it's not necessary to repeat often, like monthly, every 3 months. Sometimes on clinical trials, we often do bone marrow biopsies every 3 months, 6 months, because we're trying to get as much information as possible to see if the treatment is changing anything in the bone marrow. But most of the time, I personally do keep an eye on what's changing with the mutation, if something new is happening, or if what they have is going down in what we could sometimes call as allele burden. So I do that at least, sometimes annually, and not always from the bone marrow. Sometimes we can actually keep track of the mutations in the blood as well. So long story short, blood tests like blood count should be done frequently, and more specialized tests not so frequently.
Okay. Next question comes in from Roberto. If my test results are stable, does that mean that my disease is under control?
Um, Possibly, yes. So it depends on whether they are on treatment or not. If let's say that if somebody has a low risk disease and they don't have a big spleen, don't have too many symptoms, and their blood counts are not too bad, in those situations, if the blood tests are stable, that means that the disease is not changing rapidly and it's okay to keep track. And on the other side, if somebody is on treatment and we are seeing stable blood tests, and they're also, and at the same time, if the spleen is decreasing in size, and patients are feeling better in terms of quality of life, then yes, you can say that the disease is under control, because a number of patients, when you start them on JAK inhibitors like ruxolitinib, actually feel better, improved quality of life, decrease in spleen size, and their blood counts are also stable. And those individuals, you can sort of determine that they are under control.
Right. And then Mary has two questions. I'm going to
Yes.
group them together. Just one's a clarifying question. What test determines the percent of blasts? And then her next question is, if LDH drops to normal range, is that a good sign?
Very good question. So what test determine the blast? So in the blood counts, we use these really sophisticated automated machines, which basically measures a number of white cells, thousands, and spits out what are the different component of these white blood cells are. And the machine can recognize these blasts, and these are called automated differential counts. So basically it spits out, the number of neutrophils, which is a type of white blood cells, and it also spits out the blast percent. Most of the time it's accurate. Sometimes the machine can read certain lymphocytes as blasts, but the automated differential count will give us the blast percent in the blood. And if the lab is suspicious that it's not giving an accurate count, sometimes they go and verify it, and that's called manual differential count. So that means a human trained person looking at the blood cells under the microscope and literally counting cells and determining what blast percent they have. So that's in the blood. In the bone marrow, it's a different story. In the bone marrow, the pathologist can tell the blast percent, one, by counting actually how these cells look. That's called, again, bone marrow differential count. So they basically spits out what percent of the cells are blasts and then everything else. It's often the first thing they report. And then sometimes they also report it on flow cytometry, which is basically a machine where the cells go through in a single column, and then there's a laser that basically kind of goes through all these cells, and it can kind of determine the blast percent based on what they are expressing on the cell surface. So the flow cytometry can give a blast percent, but it's not as accurate as the pathologist is counting. Finally, the last thing is the pathologists, if they're suspicious, they stain the bone marrow slide with a specific marker called CD34. And then they can tell with the stain what % of the cells are positive. So there's kind of multiple different ways, but often I look at the blast % on the pathologist's manual differential count, and sometimes I look at either flow or the immunohistochem, which is the stain that I was talking about. In terms of the LDH, most patients, my observation and others is that when you treat with JAK inhibitors, I don't always see a decrease in LDH. But there are some individuals, if the spleen is shrinking and if their white count is dropping down, so LDH is sometimes a marker of how active the disease is. So if we're controlling the disease, sometimes it goes down. So if you see a decrease in LDH, it is a good thing. And we observed in some of the clinical trials with the new agents that we're doing, even though they haven't received approval, that when patients receive this extra medicine on top of JAK inhibitors or ruxolitinib in this case, we do see a decrease in LDH, which is indicating that it's controlling the disease probably better. So I do consider that if I see a drop in LDH, that means the activity of the disease is down.
And then our next question comes from Helga. With high platelet numbers, is it necessary to do an MRI to exclude any blood clots?
Yeah, good question again. I think I mentioned earlier that high platelet count is a feature of essential thrombocythemia, but a fraction of myelofibrosis patients, especially when they're diagnosed and not on treatment, have a high platelet count. And sometimes it can be high. It can be very high. And there is some correlation between the type of mutation they have. It is sort of our observation and the researches that's been done so far is that individuals with calreticulin mutation, for example, and have myelofibrosis, especially so-called type 2 calreticulin mutation, they have high platelets at the time of diagnosis. And the high platelet count doesn't always correlate with the risk of blood clots. And in fact, when you have extremely high platelet count, like in this case, they're talking about over 1 million or 1,100, these individuals actually have a higher risk of bleeding than blood clots. So that's one of the reasons why we try to bring it down, is because too high platelet count can sometimes cause nosebleeds and easy bruising and that kind of stuff. And you would only require imaging tests like MRI scan or CT scan if they have specific symptoms of a blood clot. So it is not necessary to do MRIs or CTs to try and find out if someone doesn't have symptoms. As I said, when platelets are really high, I'm more worried about bleeding than actually blood clots, if that makes sense.
And then next we have another question from Teresa. What is the difference between blasts and allele burden?
Yeah, excellent question. So blasts are basically the most immature cells in the blood or bone marrow. In a normal individual, we don't see any blasts in the blood. And in the bone marrow, we see about 1%. It can be up to 2% sometimes. And what these mean is that this is the most immature cell in the white blood cell production. And it goes through a series of steps, series of different stages before it becomes a mature white blood cells. So the blast count typically in a healthy individual is below 1%. It's not increased. In acute leukemias, like in acute myeloid leukemia, for example, AML, which is the most common acute leukemia in adults in the United States, they have a problem where there are too many blasts. And these blasts are very abnormal, they're cancerous, they can mature. But in chronic leukemias, like in myelofibrosis, you can have an increase in blast count to some extent, often, below 10% in the blood or bone marrow. So blasts are basically cells we can either observe on looking under the microscope or automatic machines in the blood, like I was talking about earlier, or we do special tests like flow cytometry to determine. So blast is basically a cell, and um, as opposed to allele burden is a mutation. So when you see, for example, in this case, a myelofibrosis patient, not all their blood cells are mutated. Okay. So there are some normal cells and there are some mutated blood white cells, myeloid cells, because it's a myeloid disease. And the myelofibrosis is coming from these mutated cells. And the allele burden reflects basically the amount of cells that are mutated compared to the healthy cells, if that makes sense. So what we can do is when we do sequencing, for example, let's say JAK2, we will look at what is the percent of the cells that have the JAK2 mutation versus the cells that don't have JAK2 mutation, which in this case are healthy. So that's what allele burden reflects. If the allele burden is going down, that means that the mutated cells are going down and the normal cells are going up. The only situation consistently that we see the mutated cells completely disappear is, let's say, for example, an individual with myelofibrosis had a bone marrow transplant. Then in that situation, you don't see the JAK2 mutation anymore. It's all gone because they have healthy cells from the donor. But outside of that, if you see the allele burden going down on a medical treatment for myelofibrosis, that means that this treatment is working well. So far, what we know, the approved medical therapies, none of these drugs are really bringing the allele burden down in most patients, which means that, the cancer cells are going down and the healthy cells are going up at the same time. And that's where, all these new investigational therapies, when we do those, we measure the allele burden because we want to see if these new drugs decrease the cancer cells or myelofibrosis cells in this case and increase the normal cells at the same time. So I hope that makes some clarification on, what's actually the allele burden is.
Right. And next is, are there any specific patterns in lab results or imaging that might indicate a patient transitioning to a more aggressive form of disease, such as acute myeloid leukemia or AML?
Absolutely, yeah. Typically lab results, not so much on imaging. And when we see the lab results, if I see somebody with what we call as chronic phase myelofibrosis, if I see suddenly they have a super high white count and the machine and we're seeing a large component of them are blasts, like over 20%, that's when I'm concerned that they may be progressing to more leukemia phase. And the other thing that goes hand in hand is that almost always, when the disease becomes more into an AML or leukemic transformation, we also see a drop in blood count. So that means that somebody becomes more anemic or the platelet count drop. They start to require transfusions all of a sudden, or they're feeling a lot more tired. Then I know that something's changing. So the first thing I do in those situations is look at the blood counts. Do I see a difference in the blood? Do I see an increase in white cells, blast percent, or do I see a decrease in platelets or red cells? In those cases, then we're doing a bone marrow biopsy to kind of look for it. So very rarely you see this progression to more aggressive form without change in clinical picture, like patients often feel more sicker or it doesn't usually sneak upon, although rarely, you know, we do a bone marrow for a different reason and see the more aggressive form. But in almost even in those situations, it's only a matter of time that someone is starting to feel uh, more sicker.
All right.
There's another question from Helga that um, we missed.
See. I believe she was just saying that her mom will be starting treatment next week. Um, on
Platelets. Yeah.
Yeah,
Yeah. So,
yes.
oh, okay. That's for the comment for the platelets. Yeah. Ropic interferons are typically not used in myelofibrosis, except certain unique situations. Interferons are typically used to treat either polycythemia vera or essential thrombocythemia. Um, it's possible that that's what's going on in this situation, but it's also possible that certain myelofibrosis patients that I was talking about earlier have high platelets. And, and if these individuals have low risk disease, it is reasonable, and I have also given patients with interferon to try and decrease the platelet count for low and intermediate risk disease patients. In more advanced forms of myelofibrosis, interferons are not that commonly used, but yeah, that's
And then, so you mentioned platelet counts. When looking at platelet counts, can that affect which JAK inhibitor you may choose for a patient? If the patient has really low platelet counts, could that alter your decision for a different
yeah,
JAK inhibitor? Or...
yeah, absolutely. I mentioned briefly earlier that when we start patients on ruxolitinib, one of the side effects is a drop in platelet count. So we often keep an eye on the platelets. And ruxolitinib has not been studied in people with really low platelet counts, like below 50,000 or below 50. Um, Technically, it's not recommended. Although in clinical practice, in rare situations, let's say if somebody has high platelet to start with, and we put them on ruxolitinib and they drop, slightly below 50, but they're stable and they don't have any symptoms, and they're otherwise benefiting from ruxolitinib, in those situations, perhaps it's reasonable to continue ruxolitinib. Um, but other than that, there are certain patients who can have really low platelets right at the time of diagnosis, and it can be below 50,000. And in those individuals, pacritinib is the drug that's specifically approved for this situation for patients with low platelets below 50,000. In those individuals, you can maintain pacritinib doses as usual, and kind of still get the benefit in terms of symptoms and spleen responses. So yes, there is a platelet count, selection of a specific drug based on one's platelet count. The other important thing to consider is, since ruxolitinib is sort of the most common drug that's used in myelofibrosis compared to others, is that the dose of ruxolitinib that we choose is also based on an individual's platelet count before we start. So for example, if the platelet count is below 100, then you start at a lower dose as opposed to platelet count between 100 to 200 or about 200. So um, it determines what's the starting dose for ruxolitinib based on the platelets. Um,
Right. And then Teresa, and we may have time for one more after this, but we'll have to start wrapping up here soon. But Teresa asks, are other blood values checked when a person starts ruxolitinib, such as cholesterol levels?
That's a good question. I mean, in clinical practice, I'm not aggressively monitoring cholesterol levels. Typically, but We don't really have an indication that ruxolitinib increases somebody's risk for developing, either heart disease or a stroke or anything like that. The most common side effects for ruxolitinib is sometimes we worry about there's some patients can have reactivation of shingles. So you can make a case for putting somebody on acyclovir. There are higher rates of sort of non-melanoma skin cancers. So we keep an eye on that. Not so much but cholesterol, other than that a primary care physician may monitor. Because often um, myelofibrosis patients are, in the later stages of life in 60s and 70s, and they may also have history of heart disease or stroke. So then it makes perfect justification to monitor the cholesterol levels, but routine monitoring is probably not necessary on everybody. But yeah, something that's specific to an individual on their medical history.
Gotcha. All right. And it looks like we are out of questions. So thank you again, Dr. Tantravahi. That was excellent, and you did a fantastic job answering all these questions. Um, with that, we're going to start wrapping up here. And before we go, I want to highlight the Track My Disease
Yeah,
feature in the HealthTree Care Hub. This is kind of related to our talk here today, where we talk about all these lab results and things like that. The HealthTree Care Hub has a really cool feature that allows you to track all of your labs, and not just after you connect, but it'll go retroactive as well. So you can see all of your CBC counts in one place and make it really easy for you to follow along to see if values are going up or down or whatever. So if you're interested, highly encourage you to check out the Health Tree Care Hub. Um, and then again, we have a dedicated team of patient experience people that will help you connect all of these records. If you have any questions, you can reach out to them via chat, email, phone. So we try to make it as easy as possible, but I do encourage you to look at that. And then as you leave today's session, we would appreciate you taking 2 to 3 minutes to fill out a brief survey about your experience. And I want to highlight an upcoming event that's called Building Your Myelofibrosis Care Team. This will be with a clinical nurse coordinator who specializes with MPN patients. His name is Patrick Buxton. And then I also want to give a shout out to the first ever podcast that we hosted for our myelofibrosis community. I hosted this back in December with Dr. John Mascarenas, and this was about the Sentry trial. This is an ongoing phase 3 clinical trial. So if you're potentially interested in looking at clinical trials or just want to learn more about clinical trials, I highly encourage you to check that out as well. Um, with that, I want to thank everyone for hopping on today. I want to give a big thank you for Dr. Tantravahi. Again, I think you did an excellent job with this, and I can't thank you enough. Um, but really, thank you all for being part of our community and helping us put together these events. Don't hesitate to reach out to me for anything. My email's up on the screen. I'm here to help answer questions and do whatever I can for this community. And I just want to say that I appreciate you all, and I hope that you have a great rest of your day, and I hope to see you at another webinar soon. And really, thank you again, Dr. Tantabahi.
sorry, I didn't realize I was muted. I was saying that thank you so much for having me, and thanks for your attention. So it's a pleasure to be able to participate and help you understand this disease. So hang in there.
Yeah, and so I touched a little bit on the Cure Hub event there. Um, so I actually was at the University of Utah. I was in Shannon Buckley's lab. So I was a grad student at Utah,
Oh,
and then um, ended up doing this and trying to do a little bit more patient education. But
that's great.
um, Dr. Sporov, Doug, we
Yeah,
work with him quite a bit for HealthTree.
yeah,
Um, but the Cure Hub that we have going is really cool. It helps researchers learn. It helps researchers conduct studies um, using patient data. Patients like connect their records, and then we give that access to researchers like yourself, um, so that they can really start expediting the research process. It's free for patients to sign up. It's free for researchers to use. I just wanted to make you aware of that. That they are we're just getting launched into myelofibrosis, but we are trying to enroll some patients into it so that you can start running some studies. So if you ever want to learn more about that, I'm happy to
absolutely.
talk to you. I've
Oh,
done events with like um, John Mascarenhas, Angela Fleischman, and a couple of other non Patel. Like I've worked with a decent number of myelofibrosis specialists in the last couple of months. So I'm really hoping that we start getting some more enrollees for this Cure Hub, so that we can really start
sounds
launching some
great. Yeah,
exciting myelofibrosis trials. So if you ever want to talk about it, feel free to reach out to me. I'm happy to
absolutely.
talk
Yeah,
about it. So
will do.
great.
Yeah. It'd be great if we can have some brochures so I can hand it over to every patient that we see so they can actually join this care hub. And
Yeah, if you want to do that, I can definitely make sure that you can get brochures. We have it. So we cover all different blood cancers. Myeloma is our biggest, but we also have it for myelofibrosis. AML is another one that we're in, MDS, CLL, follicular lymphoma, and then large B cell lymphoma are kind of like our core diseases right now.
yep,
But I would be happy to make sure that you guys get that. And if you
sounds
want
good.
to
Yep.
try to help get people enrolled, that would be wonderful.
Okay. Thank you, everyone.
Great.
Have a good weekend.
Yep. Thank you.